The hypoxic ischemic lesions in the prenatal life are an important subject, of great interest in social and public health, and in the center of a large series of investigation in maternal fetal medicine. The development of central nervous system is a process of great complexity. It is determined by the interaction of multiple genes that act in each step of the development, are initiated in the first weeks of the embryonic development with the creation of the neural tube and continues even after birth. Although the data about its regulation and reactions are limited, it is known that the sequence of each of the phases of the neurodevelopment have a precise chronology to complete the development and maintain its functions. Central nervous system needs a correct perfusion, with the need as well of nutrient and vascular input throughout gestation. Different situations as fetal or maternal pathology, infections, toxics, placental pathology or gestational complications, single or multiples, and in other situations difficult to identify, can lead to poor perfusion and therefore poor input of oxygen. Of all these situations, the most studied one is IUGR, due to placental insufficiency. In this presentation, we are going to explain the hypoxic ischemic damage on the central nervous system and the prenatal estimation of the prognosis. We will see that the impact of the hypoxic ischemic phenomenon has great transcendence. An important percentage are death in the neonatal period, and other important percentage will present moderate to severe sequelae in the motor and cognitive areas, which will compromise the integration of individual into society and its autonomy. The long-term sequelae are learning problems, cognitive disability, epilepsy, and different spectrums of cerebral palsy. The incidence sometimes is unknown because it will be undetected until the first years of life. Epidemiological studies estimate that the stroke that takes place between 28 weeks and the first days of life affect 1 in 4,000 newborns. The most important sequelae are those when prematurity or IUGR is associated. The perfusion deterioration can be due to ischemic, thrombotic, or hemorrhagic process, and with frequency are combined. As a synthesis, in the case of IUGR due to placental insufficiency, the first stages will present a hemodynamic redistribution with vasoconstriction of peripheral organs and vasodilation of the most important organs, central nervous system and heart. If the situation of hypoperfusion and hypoxia is maintained, central nervous system vasoconstriction is produced and cerebral lesions are produced as well as compensatory mechanisms, which are the increase of venous pressure and the constriction of cerebral vessels. And as a consequence, the damage of the capillary of thin muscle layer is produced, which are located in the subependymal germinal matrix, distributed throughout the lateral ventricles. The damage of this capillary is the origin of periventricular hemorrhage and venous stroke, which can progress to necrotic areas, cystic degeneration, or parenchyma cavitation, which can lead to mild, moderate cerebral lesions, and in the severe cases, stillbirth or neurological sequelae in the living fetuses. The location, distribution, and severity of the lesions are related with the mild, moderate, or severe intensity and the duration of the injury, but the decisive factor of the lesions is the gestational age at the diagnosis. Generally, the early the lesions are higher severity due to the immaturity of the central nervous system and the presence of germinal matrix, and in second place due to the differences in the vascular perfusion depending on the gestational age. The volume of the germinal matrix increases until 23 weeks and decreases quickly at 28 weeks. The fetus and the preterm newborn, the vascular pattern is ventriculopital, so the most vulnerable areas are the central periventricular areas, and as a consequence of the hyperperfusion, the white substance is damaged in the periventricular area. From 34 to 36 weeks, while the brain matures, the vascular pattern is ventriculofugal. being the most vulnerable areas, the peripheral, and the damage are in the subcortical white substance. The neuropathological study of the preterm newborn shows that the hypoxic ischemic lesions consist in periventricular cystic or non-cystic leukomalacia, focal or diffuse, and intraventricular hemorrhage or periventricular hemorrhagic strokes of the germinal matrix. MRI studies of preterm newborns have shown reduced corpus callosum, basal ganglia, cerebellum brainstem, and other structures responsible of cognitive impairment and other neurodevelopment issues that can be present in the infant period. Sometimes the lesions are non-specific of hypoxic ischemic origin, but are common in other destructive processes, coagulopathies, thrombophilia, drugs, traumatic, and others. In the fetus, the hypoxic ischemic lesions are chronic and can be detected through ultrasound and MRI. The most frequent is to identify an association between destructive lesions and malformation due to the destruction of well-formed structures. In the most severe cases, the lesion is global. The hemorrhagic ones of variable location is the most frequent hypoxic ischemic lesion, can be limited to the periventricular area where the germinal matrix is located, or be extended to the parenchyma of one or both hemispheres, or even in the interior of the ventricles and originate in advanced stages severe ventriculomegalia, unilateral or bilateral due to the obstruction caused by the clots. Now let's describe each of these lesions. The hemorrhage limited to the germinal matrix is frequent in the preterm newborns and less found in fetuses. It is present in the first stages of the hypoxic ischemic process and although tends to resolve, can progress in some cases. The ultrasound, preferably by transvaginal access, evidences a shining structure between the ventricular wall and the surrounding parenchyma. Easy to identify. The progression of the periventricular hemorrhage in the cavitation phase. Is seen as cystic formations, which makes it more evident. In this case, we see the follow-up of a bichorionic gestation at 31 weeks, and at 2 weeks we saw the resolution of it, which gives us a favorable prognosis. When the ventricular wall is damaged and the hemorrhage reaches the ventricular lumen, the presence of clots and ventriculomegaly are signs that facilitate the diagnosis. The appearance and morphology of the clots will change from the first days, and this makes it easy to differentiate from the choroid plexus. It is important to have into account that the normal choroid plexus occupies from the Monroe foramen to back, so any structure located in the anterior horns suggests the etiology of a clot. From 8 days, the clot acquires a ring structure with echogenic edges and anechoic content, till it is resolved or remains as a cystic anechoic or non-anechoic structure. If the clot obstructs the cerebrospinal fluid circulation at the Monroe foramens or Sylvian aqueduct or at the fourth ventricle, can produce obstructive hydrocephaly or the lateral ventricles tri- or tetraventricular compromises, also third and fourth ventricle, being progressive and severe when it can seem like the middle structure of the brain have been broken. In this case, we can see the intraventricular and parenchymal clots, which produce the obstruction of the cerebrospinal fluid. To estimate the prognosis, 4 grades were proposed, which are used in preterm newborns, but posteriorly were reduced to these 3 grades, eliminating the 4th grade of parenchymal hemorrhage, because it is considered a stroke of white substance. Although the correlation between the prognosis and these grades have not been validated yet in the fetus, the obtained results of these studies have proved that cases of milder intraventricular hemorrhage grade 1 or 2, where the prognosis is favorable, evolved to resolution and were asymptomatic. In progressive cases of grade 3 and 4 with parenchymal lesions, there is a high rate of presenting a compromised prognosis. In a review made in fetuses with intracranial hemorrhage of 3rd and 4th grade, a mortality of 50% was detected, and 41% of survival fetus had a normal evolution and the rest presented severe sequelae. Whether the case of 1st and 2nd degree, the mortality was listed at 7%. White substance is especially sensible to hypoxic ischemic injuries. The lesions can be necrosis and alteration of the normal development. In studies where an MRI and neurosonography was performed in IUGR fetuses have confirmed that chronic hypoxia provokes a cerebral reorganization that can affect the white substance, and have proven that early onset IUGR have a reduced length of corpus callosum at expenses of the posterior part, whether in late onset IUGR highlights the altered maturity of corpus callosum, show as a reduction in its thickness in the posterior part. In other occasions, it can have a progressive evolution. The blood can infiltrate a zone of the hemispheres or of variable size, causing a parenchymal hemorrhage. The ultrasound appearance of the parenchymal hemorrhage or stroke is similar to the one described in the interior of the ventricle. In the limited cases, the clot is organized in well-delimit as an echogenic structure, which can progress to an echogenic edge with anechoic content. In these cases, the prognosis is unfavorable. In its progression, having passed 6 weeks, we can see a cystic structure in the white substance and without echogenic edges, which doesn't generate mass effect. It is described as single or multiple parencephalic cysts. At last, the clot retraction can lead to a cavity that in occasions can communicate with the ventricles or subarachnoidal space. It is frequent to be left unnoticed until the cavitation phase. The neurological prognosis will depend on its size and the gestational age and the ischemic phenomenon. It is frequent to find motor and cognitive disability and seizures. In the severe cases, as early severe IUGR or severe preeclampsia, the lesion is global. As you can see in this case, in the first stages we can see a massive hemorrhage seen as a lack of tissue differentiation and progressively parencephalic echogenic periventricular focus and echogenic focus in the cerebellum are seen. In this situation, the risk of a stillbirth or severe sequelae are high. Other lesion is the schizencephaly, or sulcus in the hemispheres that go from the ventricular wall to the subarachnoidal space. Can be open lip or closed lip. In the open lip, we can see a rupture of the ventricle wall that reaches the cortex and communicates the ventricle with the subarachnoidal space. In the closed lip, structure in the ventricular wall is evident. It is accepted as a theory, the result of a destructive ischemic lesion with interruption of the arterial flow produced before the 24 weeks. It is frequently associated to ventriculomegaly, corpus callosum anomalies, cavum septum pellucidum anomalies, cerebellar anomalies, optic nerve or polymicrogyria. Regarding the prognosis, the severity of the neurological outcomes depend on the extension of the sulcus. Is severe in the bilateral extended lesions and favorable in the unilateral with limited extension due to the cerebral plasticity. Hydranencephaly is a global necrosis and an absence of the cerebral hemispheres, which are replaced by a cystic cavity limited by the meninges and occupied by cerebral spinal fluid. The most accepted mechanism is that it is a result of an ischemic stroke that compromises the 2 internal carotids at 11 weeks of gestation. The cerebral host, the choroid plexus, thalamus, cerebellum, and brainstem are normal. Nevertheless, other causes must be ruled out as the infections, such as toxoplasma or genetic anomalies. The differential diagnosis will be with the severe hydrocephaly, the allobar holoprosencephaly, and severe cases of porencephaly and schizencephaly. The prognosis is lethal in utero or in the first years of life. The risk of neurological lesion in the monochorionic gestation or the possible hemodynamic imbalance, is 4 to 5 times higher than in bichorionic gestation, and therefore 25 to 35 times higher than in singleton pregnancies. The severity of the lesions depend on the variety of the complication, the gestational age and the situation of each of the twins. In twin-to-twin transfusion syndrome, the donor can have hypoxic ischemic lesions and the receptor can present hemorrhagic lesions due to the hypervolemia. In the selective IUGR type 1 and 2, the twins have risk of neurological alterations due to transient bradycardias. The most severe situation is produced in the twin survival after the death of the other twin, with the acute transfusion and risk of severe lesion of the central nervous system between 28 and 34% of cases, and risk of mortality due to the acute exsanguination in 15% of cases. As we can see in the next two slides, there is a time between the injury and the capacity to see them in the ultrasound. In this case, we have a monochorionic monoamniotic gestation in which the stillbirth of one of the fetus occurred at 23 weeks. Since then, we follow up this patient weekly with ultrasound and every 2 to 3 weeks with an MRI. In all cases, although the lesions identified are mild or we do not see them, we should follow up the patients as we mentioned before. In this case, at 26 weeks, we evidence an echogenic reinforcement in the periventricular area of the caudate nucleus. We continue the follow-up, and at 29 weeks, we evidence severe lesions as progressive and extensive liquefaction of both hemispheres. The prognosis of the hypoxic ischemic injuries are individualized depending on the lesions. The different patterns of lesion can have long-term sequelae presented as seizures, cognitive disability, motor alterations, and variable degree of cerebral palsy. Generally, germinal matrix and intraventricular hemorrhage without ventriculomegaly and subependymal cyst have a favorable prognosis. Nevertheless, there is always a degree of uncertainty which have to be talked to the parents. Progressive ventriculomegaly, white substance lesions are signs of unfavorable prognosis with motor and cognitive sequelae. In occasions, in the milder cases, the prognosis is difficult to establish due to the factors related with etiology, the prenatal and postnatal management, the cerebral plasticity, and other characteristics of the immature brain, and also because the lesions can evolve postnatally. Currently, new MRI technologies are being investigated to predict a more accurately prognosis, or to be able to anticipate lesions seen later on with conventional MRI or ultrasound. Having this importance of hypoxic ischemic lesions in neurodevelopment, it is essential to have predictive methods in their early stage and identify those fetuses at risk. These cases, besides the screening ultrasound done in all the population, we should perform the test appropriate to each case. Serial neurosonography and MRI should be made, and add the result in the decision making, agreeing with the parents and the neonatologist, based on the estimated prognosis and the gestational age at detection. Nevertheless, it is important to administrate magnesium sulfate in the cases where the delivery is produced between 24 and 34 weeks to reduce the mortality and cerebral palsy. In the same way, the delivery should be carried out in specialized centers where their immediate attention to the newborn is guaranteed, to promote breastfeeding and follow up those babies in neuropediatric units. As a summary, hypoxic ischemic lesions have 50% of cases where the origin is not detected, can begin at any gestational age, and this will be the determining factor of the severity of the lesion. The majority is due to unknown etiologic factors, and the time passes between the injury and the ability to detect it in the image. The lesions are unspecific, evolutive, and progressive, and with frequency we have destructive and lesions associated.